valvular heart diseases. Okay. As far as what do you mean, walk through the four valvular heart diseases? Let me find this stuff here. There's a lot to go through in those four. But if you had a more specific question, let me know. Sure. Okay. Okay, let's start with aortic stenosis. Perfect. Okay. Down. Okay. Is that better? Okay, let me know if it's better. So aortic stenosis, again, remember it's a stenotic valve. What causes stenosis to happen? Usually calcification. But again, remember with aortic stenosis, as far as the age of the patient is very important. So if symptoms occur before 30, it usually means they're going to be born with something. So it's congenital, so that bicuspid aortic valve is a big one. If they're aged between 30 and 70, that's usually going to be that rheumatic heart disease. And as you start getting into the elderly population, 70 and above, those are usually your degenerative changes due to calcification. Here's your calcium with the leaflets. Remember that case we went over in class that had the calcification on the valve. They were able to see that on the x-ray. So remember that. Now, what's going on with the pressures with aortic stenosis? So you're trying to squeeze a lot of blood through a smaller tube now. So the heart, the left ventricle is going to generate a ton of pressure to squeeze all that blood through it. It's like, again, if I'm drinking a milkshake through a straw that's made for a milkshake, then I don't have to generate a lot of pressure to get the milkshake through. But if I try to get that same milkshake through a coffee stirrer straw, the amount of pressure that your lungs and your mouth has to generate, or not your lungs, but your mouth has to generate to suck the fluid up is greater because of the stenosis, the smaller tube that you're trying to suck up through. So the pressure generated by the ventricles goes skyrocketing up because it's going to overshoot. It's going to generate a afterload that's greater than what the systemic circulation is saying there should be for an afterload because of the fixed stenosis in the aortic valve. And if you look at your aortic valve, your aortic pressures, 120/90, that's normal blood pressure. That's not that bad. So that's the stenosis part. The sound part is happening right here at the bottom here, the phonogram. Again, sound. So remember, it's a crescendo, decrescendo murmur as that flow is going across that valve and makes that noise. Again, as the heart is compensating for this increased fixed afterload because of the valve that the heart is constantly pushing against, the heart is going to get thicker, and a thicker heart is going to contract more. Therefore, the contractility line goes up. Your B value goes up. Remember, B is afterload. That goes up because the gradient is there. And over time, because of the hypertrophy that's going on, the contractility curve gets affected. Remember, the contractility curve is also your diastolic curve, your filling curve. Those should all go together as you're going through all these things. Remember also with aortic stenosis, they get a concentric hypertrophy. Just remember, concentric hypertrophy goes with aortic stenosis. Those are your signs: chest pain, syncope, heart failure. The more severe you get, remember, the less your lifespan goes down with each one that you start to have. I'm not going to test you on your heart sounds. Remember how to differentiate HOCM versus AS on your test. Make sure you understand if someone does a Valsalva maneuver and the sound decreases, that's caused by a valvular stenosis, meaning aortic stenosis. Aortic regurg. Remember with aortic regurg, it's if it's in a chronic fashion, they usually are going to have signs and symptoms because they've had time for the heart to remodel and compensate for the aortic regurg. In an acute form, there's no time for these compensatory mechanisms to happen, so the symptoms come on fast. Signs and symptoms, big thing is this diastolic Austin-Flint murmur. Remember, it's diastolic for aortic regurg, so make sure you really understand and remember which ones are your systolic murmurs and which ones are your diastolic murmurs. It's going to help a lot for your exams. Remember, this is not moving. Let me move that. Hang on. Okay. Aortic regurg. The valves and the diastolic and systolic. So remember, here's your S1. There's your S2. Aortic stenosis. Anything that happens, and let me change this to highlighter. Any sounds that you hear that occur in there, systolic. Now, let's draw the next series of beats. Same thing, there's your systolic. But let's color this a different color. We'll do it in red. And now we're outside. We're in between S2 and S1. And these are going to be your diastolic murmurs. So if we superimpose aortic stenosis, sounds like that. Crescendo, decrescendo. Aortic regurg, soft diastolic rumble, early diastolic rumble, and it rumbles down. That's aortic regurg. And we'll come back to this in a second. So, diastolic rumble, Austin-Flint, having to do with aortic regurg. These are your causes, really talking about valvular issues, meaning the actual valve itself, or is the problem coming from the aorta? Callie asked about knowing specifically what the lines in the graph do or just the contractility. Know that the contractility increases. Those graphs are just to reinforce all these concepts. I'm not going to ask, but I will ask you about afterload, preload, contractility, how they are going to be affected by whatever's going on. So you will get some scenarios. The other big thing, eccentric hypertrophy for aortic regurg. So remember, it's concentric hypertrophy with aortic stenosis, but it's eccentric hypertrophy with aortic regurg. Another important thing about the difference between aortic stenosis and aortic regurg. Aortic stenosis is a problem of pressure, the pressure that the ventricle is having to generate to get past that fixed stenosis is causing the problem with aortic stenosis. In aortic regurgitation, it's a volume overload, and the volume is the problem. So let's talk about aortic regurg. There's your aorta. Here's your ventricle. And then we have our atrium on my drawing is horrible, but you guys are used to that. Can I change the color? So remember, normally every beat, our normal stroke volume, the whole stroke volume, whatever it is, if it's 65%, all of that should leave the ventricle. And when the aortic valve closes, it closes in a certain way to prevent backflow of blood back into the ventricle. Now, during diastole, because the aortic valve does not close, some of this blood falls back into the ventricle. But what also is going on during diastole, the atrium are also sending blood into the ventricle because we're filling during diastole. So with aortic regurg, because of the aortic regurgitation, some of that volume of blood that's supposed to be going out of the heart falls back in. So we get an overload of blood in the ventricle. And that's how we get the ventricular overload for volume with aortic regurg. So that's what's going on. If regurgitation develops slowly, remember there's time for all these processes to the compensatory processes to take place, but when it's acute, it doesn't happen. Diastolic blood pressure decreases because of that regurgitant blood coming back. Remember, our diastolic blood pressure is determined by the volume of blood in the system at any during when the heart's at rest, essentially. If half of that blood or a certain percentage of that blood is falling back into the heart, not the right volume is leaving, therefore diastolic blood pressure drops because there's less volume leaving the heart going into the system. So again, aortic regurg has to do with the valve itself. It can be a incomplete aortic valve or something that's causing those leaflets to fail. Aortic regurg, again, the biggest thing is that volume. So look at that diastolic pressure is only 50. So you can see this big widened pulse pressure because of some of that blood is going back into the heart. So the diastolic blood pressure drops. So that's what that's showing you there. Remember, that should stay a lot flatter on that Wigger's diagram. And then here is your diastolic rumble right there for the phonogram. Don't worry about the mid-systolic murmur that's there. Sometimes they'll hear that as well as the valve is flapping as the blood rushes past it. But for the most part is when the heart's resting and relaxing, you have blood falling back through the aortic valve, causing that leaflet to vibrate, and that's that rumble that you hear. Again, because remember, the aortic valve does not close all the way. There is no true isovolumic periods anymore because there's no closure of all the valves. Whenever you see left ventricular hypertrophy, the ventricle is dilating, remember the contractility is going to decrease. Heart is getting thicker, but they don't function very well when they get thick. Then your signs and symptoms: shortness of breath, pulmonary edema occurs. If the aortic regurg is acute, ventricle doesn't have time to compensate, and that extra blood that's in the ventricle, and this is where the anatomy comes into play when you're studying. Remember, the ventricle is going to overfill with blood. It's going to translate back to the left atrium, back into the pulmonary vasculature, and that's why they get shortness of breath. Physical exam: hyperdynamic pulses, murmurs, and that third heart sound. And then we're not going to do the sounds. Mitral stenosis, isn't that a really, really important one? Again, mitral valve is now becoming stenotic. There are some neuroscience in this one because of the blood that sits around in the atrium. In this, for mitral stenosis, think about when is blood moving past the mitral valve? When the heart is filling. When does the heart fill? During diastole. And it's late, low-pitched diastolic rumble because normally gravity is going to help for the most part. In a normal heart, gravity would just help the blood fall into the ventricle, but because we have a stenotic valve, not a lot of blood's getting in there in that last little bit. So now we need that more of that atrial kick, and that atrial kick happens in late systole. Late diastole, right before we go to fill and close that mitral valve and we start filling. So if we go back to our drawing here, and let me change the color to blue. For mitral stenosis, right at the end here, low, late pitch diastolic rumble. Because the atrium is kicking in that last little bit just to get blood through, and that causes more blood to go across that valve, accentuating the murmur, making the sound louder, and it happens during diastole. So again, stenotic valve, enlarged left atrium, because left atrium is being overfilled with a volume of blood because it can't get out. You can see here left atrial pressures are heightened. They're increased with mitral stenosis. Again, the atrium is having to generate more pressure than it should to get that blood through that stenotic valve. So it's going to squeeze harder, therefore it's going to hypertrophy. It's also going to get bigger as far as the cavitary size because it's going to hold on to more blood as well. And then here's your diastolic murmur at the end there. Biggest thing here, mitral stenosis, is going to be reduced preload, because less blood's getting to the ventricle. So therefore, preload has to go down. And when preload goes down, we know stroke volume goes down. And that's what's going on with mitral stenosis. Causes, again, rheumatic in those early ages. So if you had a patient coming in, they're 20 or 30 years old, 35, probably due to rheumatic heart fever as a child. Congenital usually presents a lot earlier in childhood or infancy because the body won't last very long with that going on that young. Again, calcific, think later on in life, elderly. So things that are very special about mitral stenosis. Remember, we have a fixed stenosis at the mitral valve. So when the mitral valve is clogged up, the left atrium starts to build up in pressure. And remember, if we work backwards, we go right into the lungs. And if we go back even further, now that we're starting to increase pulmonary vascular resistance because of all the pulmonary vascular congestion that's going on, due to that fixed stenosis at the mitral valve, now the right ventricle is pushing against that increased pulmonary pressure, therefore increasing the afterload placed on the right ventricle now, and therefore it leads to right-sided heart failure. So that's why this one's so important, because with severe mitral stenosis, they can develop right-sided heart failure just because of the mitral valve being stenotic. And all that pressure gets backed up to the pulmonary system and then onto the right side. Symptoms, shortness of breath, hemoptysis. Remember, they're going to have those pulmonary capillary pressures are increased. They don't like the increased pressure, and they pop and they burst. And that puts blood into the pulmonary, into the alveoli, and then you cough it up. Palpitations, as that left atrium size starts to increase, the atrium get very irritated. They don't like to be stretched. sending off all those weird signals, and that's what atrial fibrillation is. Neurologic symptoms, reduce outflow because blood's not leaving the atrium, it's getting stuck, leads to left atrial dilation, stasis of blood. And anytime you hear about blood not moving anywhere, being static, not going anywhere, risk of clots start to increase. So we get these emboli. Remember, a thrombus is the actual clot that's attached to the valve itself, or in the left atrial appendage, which happens a lot with atrial fibrillation. They kind of hang out in that left atrial appendage. If they break off of that, then they become an emboli as they're traveling throughout the system, and no matter where they go from there. So that's what's going on with the neurological symptoms as far as possibly getting a stroke. And we'll skip the valves. Okay, mitral regurgitations. Now we're talking about the leaflets of the mitral valve not working as well as they should. They're not closing again, so they're not providing any type of isovolumic relaxation or contraction because the mitral valve is not going to close. In the acute situation, they get left-sided heart failure, dyspnea, easy fatigability, palpitations with mitral regurgitation. So with the regurgitant valve issues, they're going to be volume problems. With the stenotic ones, they're pressure problems. So really understand that, because that's going to tell you as far as treatment, what do we need to do for those patients. Mitral regurgitation, holosystolic. So just think, the entire time that ventricle is squeezing, the entire time blood's squirting up past the mitral valve and back up into the atrium. It's going on the entire time of systole. Therefore, it's a holosystolic, goes across the entire time during systole, because this is a regurgitant mitral valve. So this is going to look like, and make sure we're still blue. Yep. Holosystolic. All the way across. So this is your mitral regurgitation, mitral stenosis, aortic regurg, and let me do that for you guys, and there's your aortic stenosis. So hopefully when you guys start getting into cardiac labs, start thinking of these things when you're listening to your partners. Okay, so MR. Again, with these regurgitant ones, if they're acute, there's no compensatory mechanism, there's no time for it to develop. These symptoms happen very fast. With chronic cases, there's time for the heart to compensate, but it's when those compensatory mechanisms fail, that's when you start getting all your symptoms. But again, hyperdynamic, displaced laterally because the left ventricle is getting bigger. It's going to push that PMI to the left and lateral. Rheumatic heart disease, again, used to be the most cases for MR. Now it's mitral valve prolapse. The cusp of that mitral leaflet pops up, and it provides a way for blood to, let me see if I can draw it out for you guys. Okay. Okay, so here's your chordae tendineae. There's your papillary muscle. In mitral valve prolapse, these chordae tendineae get loose, like in connective tissue disorders, they get loose. So instead of they pop up, and when it pops up, it provides a way for blood to come back up. Well, it'll come up that way. But that's what mitral valve prolapse is. The mitral valve leaflet just pops up, and when it pops up, it provides a way for blood to get through. Here's your acute, and there's your chronic causes again. Think about what's going on. One of the big ones that can happen, ruptured papillary muscle. And I said, remember people who've had heart attacks. Depending on where they had it. If it was the circumflex, remember the circumflex wraps around the lateral part of the wall of the ventricle. That's where your papillary muscles are. If you had a severe circumflex MI, that tissue is now dead, not going to come back. That papillary muscle can break off the wall because it's dead tissue. It becomes weaker, and the stress of being pulled at every beat ruptures it, and it falls off. And they go into flash pulmonary edema. A lot of problems because of that ruptured papillary muscle. So again, regurgitation are volume issues, volume load. Volume load, it's always think about regurgitant is a volume problem. And then different causes for your MR to occur. Here's your holosystolic murmur right there. Again, during systole when the heart is squeezing. Prominent V wave, because every beat is going to have more volume there. Again, no isovolumic phases because there's mitral valve doesn't close, so there's always going to be a leaky vessel, a leaky valve, and blood's always going to keep moving. That's why our volumes go up as well. So symptoms of MR, your pulmonary edema, again, not enough time for compensatory mechanisms. The volume gets transmitted back right into the lungs. Fatigue with MR, it's a volume problem. Less blood is leaving the ventricle because half of it or some of it is going back up into the atrium. So we're splitting the blood. So let me draw that up. There's your aortic. Here's your mitral valve. So as the heart's squeezing for systole, blood is going that way, but also some of it's going that way, back up into your left atrium. So you get blood going in both directions. All of it should go out the aortic valve, up into the aorta. That's where all of it should go, because the mitral valve should close all the way. Mitral regurgitation, the mitral valve doesn't close all the way. Half of the blood that should leave goes up into left atrium, causing a volume overload in the left atrium. Palpitations, left atrial enlargement. Anytime you ever see anything talking about left atrium getting bigger, always think of atrial arrhythmias, because again, atrium gets bigger, they start to stretch, they don't like that. Any foci can send off signals, you go right to AFib. And we'll skip that. Okay. There's our little review of valves, and I hope that helped Gabby. If anyone else has any other questions. Just curious how this works. When is JVP an important sign? Okay. So let's kind of roughly draw this out. Okay, here's your jugulars. drain into the SVC. IVC, and I'll put here for a portal for the liver. So, anytime we have backup of blood, let me change the color. Anytime we have blood coming back up because we're congested and we're pushing blood to come back up because it can't get through the right atrium because we're congested, will cause issues. So what will cause right atrial volumes to go up? Right-sided congestive heart failure. That will make that go up. So right-sided heart failure. What other things cause volume problems within the heart? Well, we also learned about pericardial effusion. Pericardial effusion prevents the heart from relaxing. If the heart can't relax, it can't fill. If it can't fill, that blood is going to get backed up. If it gets backed up, it goes to your jugular vein, and you get jugular venous distension. So pericardial effusion will do it as well. Those are the real big ones right now. Remember also that the hepato jugular reflex, when you press on that liver, it shoots blood up, which should go into the right atrium in normal people. But if they have right-sided heart failure, when they push this blood up, there's already blood sitting there, so the blood gets transferred up, and you should see the jugular venous pulsation as you're squeezing on the liver after about 5 seconds. So there's another reason for jugular venous pulsations. Hope that helps Amanda. And then Emma, don't worry about nitrous oxides 1, 2, and 3. Just know what nitric oxide does. What is it mainly there for? And then also understand also that with when LDLs start to get a little crazy there, the LDLs inhibit the work of nitric oxide. So it kind of makes all that stuff work worse. The constriction, the plaque buildup makes it all worse. I think that was all of them. That was for JVD, though. We talked about constrictive pericarditis as a problem, or pericardial effusion. Constrictive pericarditis will do it too. Make sure you know that as well. Very, very important. Beck's triad, hypotension, elevated JVP, and then also muffled heart sounds. Hypotension, they're a filling problem. They can't fill, therefore they can't fill, nothing can come out. JVP, because of all the backup of blood. Muffled heart sounds because of the pericardial effusion. There's volume of blood covering the heart. Sound can't get through it very well, so you get muffled heart sounds. So make sure you remember Beck's triad with regards to pericardial effusion. something specific to differentiate between tamponade and effusion. So I'll pull that up. Okay. We ended that lecture? Okay. It's just the tamponade is the more severe form of the effusion. So that's when you start seeing more of these signs show up. When it comes to anything that causes a pericarditis can cause a pericardial effusion. And the worst form of an effusion is a tamponade where the heart really can't. That's kind of where, if you have pericardial tamponade, that's when the pressure exerted by the pericardial sac kind of equalizes the pressure inside the heart, and the heart can't do anything. And there's no movement of blood when that happens, or very, very minimal movement of blood due to that pericardial tamponade. Like I think if you're tamponade something, it's going to stop the movement of blood. Think of a tampon. That's where the word probably comes from. Stopping the blood. So again, the blood's not going to move anymore. So it goes from pericarditis, then it can degenerate, get it worse into a pericardial effusion, because that inflammation will cause exudates to get in there, and then you have your effusion. And then eventually the effusion gets built up and severe enough, you get the tamponade. Yeah, so this is what I was talking about before, that transmural pressure is preventing the atrium from, or the heart, even just the heart in general, from opening up to accept blood. Can't do it. Yep, that can definitely lead to cardiogenic shock, and I think that's probably one of the, yep, pump failure, cardiogenic shock. Well, that's more, obstructive shock is what pericardial tamponade will be. It's an obstructive shock. It's obstructing the heart from opening. Okay, secondary type 1, type 2 blocks. I'm not going to have you know that for your exam for me. Just all I want you to understand is that the mechanisms just know that bradycardia can either be due to the SA node or the AV node malfunctioning. If it's the SA node, you're going to have reduced function in your P waves. If the AV node is messed up, then you have issues with the PR interval. Remember, the PR interval is the delay, the time it takes from the signal to get from the SA node, travel across the ventricles into the AV node. And when you see the QRS complex, that means now the signal has gotten into the ventricles. The longer that delay is, the longer it takes the signal to get into the ventricles, which means there's a block in the AV node because the P wave is still happening normally. Don't worry about the different types of blocks. You're going to do that more. So in the first degree, we just have a delay. The AV node is delaying the signal getting into the ventricles. In second degree AV block, and there's two types, but don't worry about them right now. Just know that they are blocking. Sometimes those beats get into the AV node and they just go there and they die out and they don't move past it to get to the His bundle of His, Purkinje fibers for ventricular contraction. So we have these dropped QRSs because eventually the AV node is getting weaker and weaker and it doesn't allow the signal to get through. And then following your third degree AV block, that means the AV node is totally damaged. There's no recovery of that AV node. The SA node is still going to fire normally because it still thinks everything else downstream is normal. But the AV node is blocked. It's dead. Nothing's getting past it. So the ventricles just squeeze on their own because nothing's telling the ventricles what to do. So remember the hierarchy of the pacemaker. So the bundle of His takes over when the AV node dies off. Bundle of His is about 40 to 60, 20 to 40, right around there, 40 beats per minute is where the bundle of His is. And then as that dies off, then it goes to the Purkinje fibers and they're even lower. So that's kind of a gist about what's going on with those heart blocks. You're going to learn how to differentiate the different heart blocks in EKG. As far as case studies, I don't know how many, but there are going to be my basic, straightforward questions. The majority of them are going to be those straightforward ones. Probably maybe 15, I don't know for sure, maybe 15 of those vignette questions. But even then, it's going to be like, why is this patient having swelling with their inflammation? It's because of increased vascularity. Why is this patient? They're very straightforward questions as far as the case studies. Kind of similar to what we did in class. You'll have this scenario. They have aortic stenosis, and then what are the things that could happen with aortic stenosis? Those things, what are the, like, so on and so forth. That's basically those scenarios, but they're not going to be very in depth. They're not going to be, again, they're not going to try and trick you or anything. In your CMS class, that's when they'll start getting into those very detailed vignettes. I only went through that more in detail in class just to get you guys thinking in that way. So when you start getting into these scenarios and reading these vignettes, you kind of know how to read through the material. What does it mean as you're reading those vignettes, just to get you better at the exam taking skills. But a lot of them would just be those straightforward. What is this? What is that? What is this? The next units on pulm and derm were a lot more straightforward than cardio was. So, a little better material. Well, easier grasp. Very straightforward. Okay, for AVNRT, do we just need to know that the impulse re-enter is slow and starts a continuous loop? So the AVNRT is an example. And the reason why we did that slow pathway and the fast pathway are to show you that there are two pathways that have to exist. In normal, healthy individuals, the only one pathway we have is through the AV node. And yes, we do have a fast and a slow track. And the reentry rhythm of AVNRT is a rhythm that exists because there are two pathways set up. If we assume that normally the impulse goes down, hits the AV node, waits, and then goes through, that's the normal pathway, and we consider that one pathway. With WPW, we have an extra pathway over here. So the whole slow and fast pathway in the AV node, we can consider this to be a pathway 1 and a pathway 2. There just has to be a secondary pathway for this reentry to continue. So that's really all you need to know as far as the reentry tachycardias. Know the most common one is WPW, and it's a reentry circuit. The only way these AVNRTs or the WPWs can occur is there has to be a premature atrial contraction that has to occur at a very specific time sequence to allow that fast and slow pathway to kind of build up. I'm not going to ask you very much detail about that. Just know, again, reentry pathway, there's two pathways. WPW is the most common one, but AV nodal reentry tachycardia is another a reentry circuit that can be developed as well. Kelly asked, can you explain what you meant by knowing the preload afterload, meaning like knowing stenosis murmurs afterload increase? Correct. So okay, so in this case, it's a stenosis. Right? So stenosis has to do with a pressure problem. And if you look at our preload, let me just erase some of this stuff. Okay. We have a change in our afterload because we're having to generate more pressure. So afterload goes up with stenosis, aortic stenosis, because we're going against a fixed valve. When you get to aortic regurg, in this case, compliance improves. We're holding on to a lot more blood. Volumes shift all the way over, but if you look, what's the big thing with regurg? The problem with regurg is volume. So we have a volume problem. So because it's volume, if it has to do with volume, preload. Now look at preload. Let me go to a highlighter. Went from here all the way out to there. That's preload. Afterload is relatively at the same line. So afterload really didn't change very much. Because with aortic regurg, remember, this is not a pressure problem. This is a volume problem. So afterload doesn't change very much, but preload, look how far out preload went. Remember, this is left ventricular end diastolic volume. So at the end of diastole, how much blood's in the ventricle? Well, it's going to be a ton because in aortic regurg, we're getting fed from the atria for a normal output coming back into the heart. But then we have the regurg of the blood coming back in. So it's a volume issue with regurg. And we look at mitral stenosis. With mitral stenosis, this is a volume problem, preload. We can't fill. So with stenosis, mitral stenosis is preload. And let's look at mitral regurg. Again, regurg, volume problem. Preload goes way to the right. Stroke volume massively increases. Preload, roughly the same. And remember too, with mitral stenosis, this is a problem of the mitral valve. That's why preload doesn't change here. This preload is left ventricular. This whole graph is looking at left ventricular volumes, left ventricular pressures. We're only seeing the effect of the mitral stenosis in the ventricle. The effect is less volume of blood because of the stenotic valve. The pressures in the mitral, in the atria went up right there. Oh, no, I can't see it. Left atrial pressures, 25/14. They went up. Left atrial pressures went up because it's having to squeeze now. And it's also having more blood in there as well. So the pressure goes up. But it's having to squeeze more to get through that stenotic valve. So that's where the pressure wound up in the mitral, with the mitral stenosis in the atria, reflected there. You won't see it in this graph because the left ventricle is going to be fine. There's no issues with the left ventricle in mitral stenosis. So I hope, Callie, that answered your question with regards to those things. And your ENT class is canceled tomorrow afternoon. Okay, transudate and exudates. Biggest thing really comes from like, what's the source? Transudate is usually gonna be watery, like a due to hydrostatic pressures pushing things out. But the exudate's more like an infection type stuff. I'll have that. I think it was the first one. Oh, it's in the infectious one. Hang on. Okay. Okay. So a transudate, biggest thing here, increased hydrostatic pressure, heart failure, volume overload from kidney failure. All that extra volume of blood is exerting a hydrostatic pressure. Remember, hydrostatic pressure is the push. It's pushing the fluid into the interstitial space, which is causing a transudate to form. Or by decreased osmotic pressure. Decreased osmotic pressure is the suck. Remember, that's the oncotic pressure. So things that will have low proteins, liver failure. Liver failure, you're not going to be producing a lot of proteins. Or, and this is the problem with renal failure, is you're spilling proteins into the urine. All those proteins should stay in the blood that are providing that oncotic pressure, and you're losing them into the urine now. So your oncotic pressure in the blood goes down. Again, more push factors that are favoring filtration. That's why they have, they are watery, and they have a low protein count. There shouldn't be any protein at all in that transudate. An exudate are due to high protein contents. And that high protein content is drawing fluid into that space. That's why these are usually inflammatory based, more localized to a certain area. A transudate can be like heart failure. Remember, the legs swell up. But an exudate has a blister. Okay, localized. You wore heels or a shoe that was brand new and it rubbed against your heel. And wearing it all day caused constant friction in one little area. Okay, those two layers of your skin pulled apart. Fluid got into that area. That's an exudate that got into that area from a localized inflammation due to the constant rubbing. But it's very watery. If you've had blisters and you pop them, it's a very serous solution. That's obviously less degree of damage. When you start getting into large amounts of fibrinogen, that's your scab formation. If you've seen a scab formation, there's pus in there, there's protein in there, obviously from the dead cells that are going on. And then finally, your purulent exudate, which is pus. And these are usually due to an abscess, an empyema. Cancers can also usually cause exudates. So if you have a pleural effusion, but it was an exudate material, it was pussy and nasty, that's a sign that there could be cancer, maybe. But again, these exudates are not normal. The transudate is usually due to either increased hydrostatic pressure or decreased oncotic, but the exudates are from this inflammatory process. Something is wrong that's causing that to happen. There's some sort of underlying condition that'll cause an exudate to form. So I hope that answers with transudates versus exudates. You're welcome, Gabby. Sarah, do you mean type 1 and 2 or type 2 and 3? Type 2 and 3, okay. Type 2 and 3. Okay, so here's your type 1s. Okay, type 2 hypersensitivity reaction. These are antibody mediated, or called, also known as cytotoxic. So the C, so cells have to touch. Just think of cells touching. Anything that has to do with cells touching. And the biggest one is the red blood cell transfusion reaction, RH, hemolytic disease of the newborn. We went through that whole thing in physio regarding the RH factor. Again, think transfusion reactions, agglutination. Things are clumping together, these cells, and it happens in the bloodstream, usually for the most part. That's why ABO transfusion reaction, that's why we all type and cross before every transfusion of blood to make sure that the bloods are compatible to prevent a type 2 hypersensitivity reaction. So that's cytotoxic. Cells have to touch. Type 3 is the I, the immune complex related. These are antigens that are binding to an antibody. Okay, so those antibodies, the IgG, IgMs, the antigens, whatever's going on in the body at the time. Again, if it's an autoimmune reaction, serum sickness, glomerulonephritis, lupus, almost sets the body into an autoimmune where it starts to attack itself. So immune complex, the I, antigen, antibody complexes, and wherever those things gets lodged, especially in like lupus, if they get lodged in the, and we'll go right to it right now actually. Right? If those antibody antigen complexes all got lodged in the lungs, you'd have pleural effusion. If they got lodged in the heart, then you would have cardiomyopathy and heart issues with lupus. If those immune complexes lodged in the kidneys, then you have lupus nephritis. If it's in the bones, arthritis. Right now it's phenomena, so on and so forth. Wherever those immune complexes gets lodged, that's where you have the issues with lupus. So I guess I answered your question, Sarah. And then Caitlin, regarding concentric and eccentric, just know that the concentric hypertrophy is with AS. Oops, not that. Yeah, I do. Okay. So aortic stenosis gives you the concentric hypertrophy. Aortic regurg gives you eccentric. That's all you got to know, because it's going to tell you on the echo report. And again, this is a confirmatory diagnostic test. You're going to get an echo on these patients anyway, but if they have concentric hypertrophy and you hear a crescendo, decrescendo type murmur, that just all things are just confirming they have aortic stenosis. Yes, this might be the way. I'm trying to figure out how the way to go. So this is the back. Okay, different types of shock, sure. Oh, okay. So hypovolemic is exactly what it sounds like. There's low volume of blood. What is going on? What could be some causes for hypovolemia, hemorrhage, trauma, surgery, burns, fluid loss? Just think we don't have enough blood. We can't fill the vascular system. What's the body going to do to compensate? Vasoconstrict to keep all the blood in the core, to keep the brain working, the heart, and so forth. That's why they have cold, clammy skin, because they have a severe vasoconstriction going on. Hypovolemia, everything's being shunted to the core. This slide just kind of goes over and explains how the body is going to try and compensate for the hypovolemia, but unfortunately, because we have usually an open wound, the cardiac output that increase for the compensation actually makes the bleeding worse, and the shock gets worse. Distributive shock. In this case, just think of anaphylactic shock. Distributive shock is a dump of histamine. Histamine is the problem. Histamine causes marked vasodilation, and our blood pressure drops. Yeah, you can, Emma, depending on the acronym. Most of them I'm pretty good with. I won't give you any weird ones. So think of anaphylactic shock. It's vasodilation because of the histamine, and because they have vasodilation, skin is going to feel warm because they have blood going to the tissue. That is your distributive shock. Also, neurogenic shock, people falling off ladders, causing issues with their cardiac output. Postural syncope. Septic shock, that usually goes on in the ICUs. That's distributive shock. Cardiogenic shock is pump failure. The left ventricle is not working anymore. Massive LV infarct. Cardiogenic, cardiac is the source of the shock. Pump failure totally. Your obstructive shock, this is the shock that is caused by an obstruction. Something is blocking this from happening. And the vasculature is going to be your pulmonary embolisms. Mechanical, because the heart can't relax. You get decreased preload versus an actual pump failure. All of these things all have in common reduced preload, which you can't see because I'm in the way. But let me put it over here. Reduced preload. The heart can't relax. So those are the types of shock. Okay, so compliance going to the left with preserved ejection fraction. So we had two forms of heart failure. We had heart failure with reduced ejection fraction. Reduced ejection fraction means systole is messed up because our ejection fraction got weaker, which means we have less muscle to do things with. So contractility is affected. So in heart failure with reduced ejection fraction, remember that used to be called systolic heart failure. This is a squeeze problem. Okay, so in that pressure volume loop, the contractility curve is going to be messed up down to the right because our contractility got reduced because we have reduced ejection fraction. Conversely, we have heart failure with preserved ejection fraction, so our contractility is fine. Nothing is wrong with our contractility. Our issue is with diastolic problems, which we also call filling problems. And our filling problems we call our compliance line. Our compliance is off with preserved ejection fraction. So in the pressure volume curve, in a normal situation, here's your compliance line. Because our compliance is getting worse now, because we have filling problems, we have diastolic dysfunction. When the curve gets worse, it shifts up. Remember, what is compliance? The change in pressure over the changes in volumes. Volume, pressure. At any given volume, we used to have a pressure down there. Now we're up there. Up here at our LVEDV. There's our volume line. That's where it was. That's where it is now. For the same volume, the pressure went up. That means our filling has gotten worse. Our compliance has gotten worse. Because for that same volume of blood that we were able to have before, now that same volume is exerting a pressure because the heart can't relax anymore. Remember, relaxation allows the heart to fill, and that gives it the compliance. When we lose the relaxation, we lose our compliance, we can't relax anymore, so that loss of compliance gets relayed into pressure, and pressure goes up. And that's why the compliance line, when compliance weakens, the line goes up to the left. When compliance improves, it goes down to the right. Contractility is the opposite. When contractility improves, the line shifts left. When contractility weakens, the line shifts down and to the right. Compliance is the opposite. When compliance weakens, the line goes left. When compliance improves, the line shifts down and to the right. Hopefully that answered your question, Callie. Common mistakes is confusing the valves, confusing the different types of heart failure, the different types of cardiomyopathies. They all have distinct features, and I really try to highlight a lot of those features when it comes to like the cardiomyopathies, the different types. Just really read the questions. Just like I said with like physio, when you have, venoconstriction versus vasoconstriction. Venoconstriction is only referring to the veins. So like if you read too fast, you may miss a key piece of information. I don't think I did any real application questions like I do like really major thinking questions in this one. Understanding the difference between arterial disease and venous disease. It's basically really the biggest hiccups are in the contrasting ones. Arterial versus venous disease. HFrEF versus HFpEF. The 4 valves. The 3 cardiomyopathies. The 3 types of tachyarrhythmias. What are the causes? Make sure you understand, the different, the different types of each tachyarrhythmia. Stuff like that. Those are the big things. Like I'll ask you, what's the most common, an AV node or WPW is an example of what type of tachycardic rhythm? Re-entry rhythm. That's the type of question you'll have. They'll be straightforward, stuff like that. But at the same time, there'll be some questions that, make sure you understand the concepts. But you know how my exams are. They're not bad. You're welcome. If anyone has any more questions, I'll answer them. If not, I'll just end it now, but I'll give you guys a few more minutes. Okay, you're welcome, guys. Good luck tomorrow morning. You guys will do well. Just read the questions. Take your time. It's not a rush. And I'll see you guys in the morning. Have a good night, everyone.